Thank you, sir. Thanks also thanks for the opportunity, sir, and the organizers. So I will keep my talk short. I know we are all exceeding the time limit. So my talk will be on the role of immunotherapy in the early stage non-small cell lung cancer. So just beginning with the trial. So this is the hypothesis what was based on which these trial platforms have done. So at the top you can see the role of immunotherapy in actual setting where they hypothesize because in those patients who have been resected non-small cell lung cancer, there is a post-surgical stress which leads to the increase in the repertoire of T cell because of the prostaglandin catecholamines mediate excess of T cells. And at this moment, if we use the immune checkpoint inhibitors, it prevents the synapsing between the PD-1 and the PD-L1 and leading to the reactivation or boosting of the T cells to eliminate the micrometastatic disease. This is in the post-operative setting, and in pre-operative setting, again the same concept with the boosting of the T cell repertoire. It helps in reducing the shrinkage of the tumor burden, helping in facilitating most complete resection, and further also it take care of the micrometastatic disease. And same both the concepts combined in the perioperative, initially prior to our surgery and post-operative setting with the help of immune checkpoint inhibitors. So based on this rationale, many trials have been started and some results are out, very promising results. And initial one was checkpoint 816. So it was a phase 3 randomized open label trial where newly diagnosed resectable stage 3 both stage 1B to stage 3 non-small cell lung cancer with no EGFR or ALK alterations were randomized 1:1 with nivolumab in combination with the chemotherapy or only chemotherapy, the comparative arm. The stratification was based on the stages, PD-L1 expression. Here, this was in the preoperative setting, and after around 6 weeks, the patients were taken up for surgery, and based on the histopath, they were options were either for adjuvant chemotherapy or radiation. So the primary endpoint here was the PAT-CR rate and the event-free survival, and the key other secondary endpoints were overall survival and major pathological response. So if you see this graph, we can see the pathological CR in the chemotherapy was 2.2%. However, when the immunotherapy was combined with the chemotherapy in the preoperative setting, the PAT-CR was increased to the tune of 24%. The difference was huge. It was 20% difference chemotherapy versus chemo plus IO combination in the preoperative setting. And first plot, you can see the benefit was across all subgroups, whether it be a stage, whether 1B or 2A, or a histological, either squamous or non-squamous, or various PDL expression, whether less than 1%, 1 to 49, or more than 50%. So whatever, and even the chemotherapy background, it was persistent. The benefit was across all subgroups for use of immunotherapy along with chemotherapy. The event-free survival, the primary endpoint, the median event-free survival was 21 months in the chemo arm. However, it was not reached in the nivo and chemo combination over here. So almost 3 years difference was 43% in the chemo arm, which was increased to 57% when the IO was combined with the chemotherapy arm. The overall survival data, again, though it is not mature enough, we can see the wide separation of the curve starting from 12 months onwards and maintaining the separation per se. So 36 months, it is 64% in the chemo, it increases to 78% if the immunotherapy has been used upfront along with the chemotherapy. Coming to the pathological response, once we have a pathological response, it correlates with event-free survival, though we are using the chemotherapy or non-chemotherapy arm. Another important was the major pathological response. Here, even though the major pathological response was attained with the chemotherapy, with the use of immune checkpoint inhibitors in the nivolumab, this trial has shown there was some improvement in the major pathological response compared to using only chemotherapy arm. So overall, this study concluded that in the tumor, whenever we have a PAT-CR or we have major pathological response, it correlated with improved event-free survival with the use of neoadjuvant nivolumab with the chemotherapy background. And the event-free survival was improvement. The improvement was seen who had PAT-CR was regardless of the baseline stage of the disease or PD-L1 expression first. And this depth of pathological regression, what has been achieved, it is predictive of event-free survival at the 2 years. So overall, the safety, again, we have been using immunotherapy now, and it was consistent. So overall, they concluded that the result supports that the pathological response was maybe an early indicator of event-free survival benefit with the use of neoadjuvant immunotherapy along with the chemotherapy background. So following this, we have another data, anti-PD-1, Keynote 671, where pembrolizumab was used in the perioperative setting along with the chemotherapy. Here again, the standard phase 3 double-blind randomized study, stage 2 to stage 3B non-small cell lung cancer, there was who are resectable status, received 4 cycles of chemo background, but chemo here was for squamous, it was gem-cis combination, and non-squamous is pemetrexed and cisplatin combination. So 4 cycles of chemotherapy prior surgery along with pembrolizumab with no placebo comparator arm, followed by the 1 year of almost 1 year of pembrolizumab maintenance versus placebo. Again, the primary endpoint being the EFS and OS, and key secondary endpoint measure pathological response and pathological CR. Just to show how it was tolerable, it was seen in those intensive population, there were approximately 400 patients in both the arms, and almost 75% had completed 4 cycles of IO with chemotherapy. And those who had underwent surgery, like 82% who had completed pre-operative therapy, underwent surgery, and almost the adjuvant chemotherapy, adjuvant therapy, whatever form, the complete 1 year of IO was given to almost 40%. So it was fairly tolerable, almost 80% undergoing surgery, 80% undergoing neoadjuvant, whatever plant therapy. So, and the baseline characters again was perfectly matched. Majority were non-squamous, and the stage 2A was around to the tune of 40 to 54%, and nodal status N2 was to the tune of 42%. PD-L1 status equally matched between less than 50, 1 to 49 less than. Another interesting was the EGFR and ALK. It was present in around 3% of the study subject in both arms. So the surgery, around 98% R0 resection was achieved, and major surgery in both arms were lobectomy to the tune of 78%. The primary endpoint EFS. At the median follow-up of around 25 months, we can see how beautifully the KS cells are separated. The median EFS was around 17 months in the placebo arm. It was not reached in the arm which had immunotherapy, that is pembrolizumab given along with the chemotherapy. Across all subgroups, again, it was well maintained, whether it's the histology, whether it's the PD-1 status, and even the EGFR mutation and the ALK mutation, though the numbers are very small. But overall, the analysis of substratification favored pembrolizumab along with the chemotherapy. Overall survival, though not matured enough, again, we can see there is a suppression of the over the last, after 2 years, gradually the suppression. Maybe future data can help us to delineate it more. Coming to the pathological response, which is the secondary endpoint, the major pathological response was 11% in the only chemo arm versus 30% in the pembrolizumab along with the chemo arm, almost a delta of 19%. And the pure pathological CR, we had a delta of 14%, almost 4% in the chemo arm, jumping to around 18% in the pembro arm. The PAT-CR status, again, we know that once we have a PAT-CR status, it correlates with the event-free survival. So even we have a PAT-CR and a major pathological response, the immunotherapy benefited both who have not attained the PAT-CR. You can see the last the graph, 2 graphs in the Kaplan-Meier. Those who had not achieved the PAT-CR and those who had not attained the major PAT-CR, major pathological response, there had been some benefit with the use of immunotherapy in these two subjects. So overall, the adverse events are very tolerable. We have been using pembrolizumab, and everyone have a fair experience with, majorly being the nausea, neutropenia, bit, and constipation, appetite, fatigue, fairly tolerable and fairly well controllable with the usage. So overall, the investigator concluded that this combination of pembrolizumab with chemotherapy was associated with significant improvement in the event-free survival compared to only chemotherapy, where the EFS was not reached in the immunotherapy combination arm, and OS difference, though presently the statistically not significant, but showing to be promising OS result. So overall, this perioperative approach of pembrolizumab had significant improvement in the pathological response, and the benefit was irrespective of the histology or irrespective of the PD-L1 status. So again, following this, we have another trial coming up. There is a Neoadjuvant study based on the same result. There's a new anti-PD-1 toripalimab, which was studied along with the chemotherapy. We have an interim analysis which was published. Here again, the standard design. It was a resectable stage 2 to stage 3 non-small cell lung cancer without any driver mutations. Toripalimab was combined with the chemotherapy, initially given 3 cycles pre-op surgery, and those who underwent surgery had received 1 more cycles of extra chemotherapy along with the toripalimab, followed by only toripalimab maintenance to the placebo. The primary endpoint being event-free survival, and the secondary endpoint was as passive. So baseline again it was perfectly matched, comparable. The treatment summary: the surgery was performed almost in 82% who were able to undergo surgery, and those who had undergone able to undergo surgery, almost 90 to 95% had a R0 resection rate. Lobectomy again being the major surgery, around 80% lobectomy. So over the interim analysis, whatever we have, the event-free survival, the median event-free survival of 15%, 50% in the 15 months in the placebo arm versus in the toripalimab and chemotherapy arm, it was not increased. The 24 months event-free survival jumped from 38% of chemo arm to almost doubling of 24 months EFS to 64% in the toripalimab and chemotherapy arm. Major pathological response again only 8% in the chemotherapy arm to the tune of 48%. There is a difference of around 40% difference if the toripalimab was used with the chemotherapy background. And the event-free survival was seen irrespective of the PD-L1 status, less than 1%, 149, or more than 50%, and irrespective of histology. Secondary endpoint, the PAT-CR, again, almost delta of 23% improvement in the PAT-CR rate, event-free survival improvement, the 2-year overall survival, a marginal improvement, though not significant. Safety, again, it was tolerable, no much of grade 3, grade 4 toxicity, leading to discontinuation per se. So overall, the investigator in the interim analysis concluded that combination of toripalimab with chemotherapy resulted in significant improvement in EFS and higher major pathological response and PAT-CR rates. And it was consistent across with the key subgroups, either PD-L1 expression less than 1 or up to 50%, or in the histology, either it's a squamous or non-squamous type. At the last, we have AGON study, which is again a perioperative regimen where durvalumab was used with standard platinum-based chemotherapy, randomization again 1:1 with the stage 2A to stage 3B, and here they with the negative driver mutation. It was after the neoadjuvant usage of durvalumab, after the surgery, the durvalumab maintenance was used for around 12 cycles in the trial arm and placebo in the 12 arm. And the primary endpoint was PAT-CR and EFS, and secondary was major PAT response. Again, as we have seen in the other trials, the event-free survival, the median event-free survival is the cutoff. We have seen the placebo arm had around 25 months of event-free survival, and it was not reached in the durvalumab along with the chemotherapy arm. The 24-month event-free survival, we can see there is a separation, 52%, increasing up to the tune of 63% in the arm which we had the durvalumab along with the chemotherapy. Again, the benefit was across all subgroups, majorly across the irrespective of the PD-L1 expression where the tumor cell percentage was taken, the benefit was seen, and across the stage of the disease, even the stage A and more than stage 3 disease driving majorly the benefit. And irrespective of the platinum, whether it's a platinum or carboplatin, the benefit was seen across the spectrum. The secondary endpoint, the PAT-CR rate, again a delta of around 13%, 4% in the placebo with chemotherapy, and 17% with the usage of durvalumab. So overall, till now, what we have seen here is above the graph, we can see when only the immunotherapy are used in the either in the perioperative setting, and those who are able to undergo surgery, they have seen that the overall response rate remains to the tune of around 5 to 60%, major pathological response to the tune of around 20 to 40%, and PAT-CR ranging to the tune of around 10 to 12%. However, when this immunotherapy is combined with the chemotherapy, when we use the combination chemo with immune checkpoint inhibitors, we have seen the improvement in the overall response rate to the tune of 60 to 80%. Major pathological response significantly improving from 60 to 80%, and PAT-CR also decent PAT-CR from 40 to 60% attaining PAT-CR. So it shows the improvement in all the outcomes when we have this chemotherapy combined with the immunotherapy agents. So with this, we have a number of trials coming up. We have a very fascinating data this year or next year, which may change the standard of practice what we have been doing now. So a lot of outputs expected. So with this, I conclude my study talk, and thanks for the opportunity.
Thank you, Dr. Kaushik. So I think in the future, we are more and more number of the immunotherapy molecules are available to use in this neoadjuvant. So what number of proportions you are treating in surgical? What number of in your practice?
Sir, definitely the early stage lung cancer that our center it is still low. Maybe able to stage 3, still we have around 20 to 30% till now. And but last taking our experience in our center, last 2 to 3 months we have used this immunotherapy combination in perioperative setting in 2 patients and good results till now.
Yeah.
We have tried using that.
So thank you, Kaushik.